This is the very core idea of our platform. It's smart and predictive analytics. One of the things we found out that very much has to do with the patient length of stay prediction is actually the physician who is doing the procedure. We are seeing two physicians performing same procedure on somewhat similar people. Physician X patients stay longer than physician Y patients. Imagine yourself a head nurse building a schedule. They know how many people they need to put on any given shift into the future. Now, if you know in advance how many people you need, you have some leverage.
Sergey, thank you so much for hopping on the podcast today. I've been excited to speak to you. And for the audience listening, we have Sergey, co-founder, chief nursing officer at In-House Health. In-House Health is an AI-driven scheduling and management platform for modern nursing teams.
Hi, Bert. It's my pleasure to be here. Thank you for having me.
Absolutely. Thanks for making the time. So, Sergey, I want to jump right in. You spent nearly a decade in the neuro-ICU before you dove into the health tech space. What pulled you into this new chapter of your career, and what led you to co-found In-House Health with your other two co-founders?
Yeah, this is one of the big questions. So I did spend almost a decade in neurosurgical ICU. It was a big one. I was doing shift management. I was doing clinical. I was a clinical instructor doing all that. And you know how it is in hospitals. It's always hectic. You work endless weekends. You work nights. You work this and you work that, and it's you always see only your next shift, and you have this tunnel vision. And at some point, I realized I'm slightly burned out, and I really want to try to do something else. So I kind of switched to health tech. I didn't immediately go and found In-House Health. I spent over a decade doing other stuff in other health tech companies, but I always stick to healthcare because this is what I understand, this is what I love, and this is what I do. I've been doing, learning my way around from the most junior positions like QA support integrations team lead, directorial positions, traveling between several companies. And at some point, I realized I was ready to do something significant, and I joined Ari Brenner, who is the CEO of In-House Health today, and he's a founder. And, did the slip of faith. I jumped in and I said, wow, this is a great idea. I want to try. I want to see what happens. It was about 3 years ago. I would say it's 3+ years ago.
It's always amazing that when I interact with folks in the health tech space that, have this healthcare background. You worked over a decade, like you said, in neurosurgical ICU, and sort of sounds like you did a variety of roles in the health tech space and now have really jumped into this scheduling and management piece of healthcare, which has been big. It was impacted during COVID, right? As we saw the influx of outside agencies and local tenem nurses. But let's dive into that because I want to unpack that a little bit with you.
Sure.
From what I see in the industry, skilled nursing facilities, long-term care facilities, they face a lot of staffing challenges, especially with their nurses. What are you guys seeing on the ground today? What are you seeing on the ground? And what are operators in healthcare still struggling to get right?
That's a great question. On the ground today, what we see as a company, not necessarily just me, but everybody else involved, we're seeing that staffing in both acute and long-term care is still in crisis. I think I want to focus on the long-term care. 92% of nursing homes, they report significant or severe staffing shortage. At least half of them probably have had to limit their new admissions because they simply don't have enough caregivers. There is overtime issues, there is costly agency staff just to cover shift, which is unsustainable. You spend a lot of money just doing that, and you know how the healthcare systems always run tight on money, unfortunately. The recruitment is hard. The facilities competing with hospitals, traveling nurses, agencies, and so on, because people, especially after COVID, like you mentioned, they want to see this work-home balance. They want to everybody wants to make more money, and people just don't want to commit to single place and to rigid staffing schedules. So they go find something else, and there is a competition out there. Recruitment is hard. The retention is also very challenging. There's turnover numbers that are as high as 30% a year. So I guess operations still struggling to make it right. Financially, 85% of facilities run at a loss or break even So they just can. There is a limit how much they can improve pay and staffing. They do know the culture. They do understand the flexibility, career development, all that matters. But so many are stuck in short-term crisis management instead of building long-term workforce solutions, let alone investing in sophisticated scheduling or technological tools.
Spot on. I mean, you painted the picture perfectly, I think, of the current problems with staffing. And I know you called it a crisis, but I want to go back to that point you just made on focusing on long-term care, because there's a lot of talk in the industry about staffing shortages, like impacting your largest hospitals, your community hospitals, your large health systems. Why the focus on like long-term care here specifically? Like, what are you guys seeing there that has really gravitated your team towards focusing on long-term
I think
care?
when I say long-term care, I think it's like this, this long, lengthy process which kind of involves around everything because healthcare, you can't really divide it into acute or long-term. Well, you do that in real life, but it's all interconnected. And when we say
They come
long-term
together.
care, yeah, we basically cover all that range of healthcare services where you cannot just probably can't just focus on something very, very limited on scope and then turn it into something different, saying, "Hey, I'm talking about only long-term care." While, in my opinion, in my vision, it's all interconnected. The short-term care is simply embedded inside that. So, if you want to build a creative, sustainable, and correct solution, you probably need to talk on a higher level rather than a smaller level, while the smaller embedded inside the bigger picture. This is maybe I
Right.
wasn't clear previously, but this is the vision that I have that we have in in-house health.
Makes sense. I'm sure with your background as like a neurosurgical ICU, you saw a lot of that connection across the space,
Exactly.
you know?
Exactly.
Yeah.
And it's funny that you mention it because when in the ICU, it's like it's a battlefield. You like struggle. You have patients like unfortunately dying or being very unstable, and then they're kind of stable. They're kind of okay. They're done with the ICU. They're still very sick, but then they go out. And I've heard from people around me, we don't really know what's going on with them past that door. You know,
Mm,
there is the step down unit, then there is the regular unit, and then there is maybe rehabilitation, especially for the neurosurgery, all those traumas and all those whatever.
right.
And then, but you don't know what's going on with them. So here's yet another point: long-term care, right? Because not
Mm,
only you've done your part in the ICU, which is super important, you've done your part, but there are other people doing things with that same patient. The patient didn't go home yet.
right.
He's being treated in maybe probably within your organization yet.
Right. Right. Depending on their age and acuity, they may go to like a rehab hospital
Exactly.
or
Step down
a nursing
unit,
facility.
all that. Yeah.
That's what makes long-term care long-term. I mean, that's a great example. And, diving a little bit more onto how you guys are addressing that, I know like, the digital schedules have been around for a while, right? Like digitizing schedules. But from what I have learned about in-house health and the work you guys are doing is you guys also predict demand, right? Like the whole using the example of long-term care, being able to actually like predict, okay, we have this amount of demand coming up in our patient census or patient flow. This is what we can predict moving forward. But without me trying to speculate what it actually does, can you walk us through how your platform that you guys have created actually helps predict this demand and ultimately avoid these like last minute agency costs or under or overstaffing,
Yeah, that's very interesting because this is the very core idea of our platform. It's smart and predictive analytics. Of course, it's based on sophisticated algorithms and machine learning and all that, and but eventually our platform provides future suggestions and real-time adjustments based on constant data flow and always learning algorithms. So I've heard many times people being skeptical about what I'm trying to say. Hey, how can you predict demand? Oh, you're looking at the previous trends, at the past trends. So yet we have to start somewhere. We have to teach the machine to find correlations and find bits and pieces of information the human eye cannot see in huge amount of historical data. But you know what's the funny part? Your algorithm gets obsolete. Well, starts getting obsolete at the moment you finish training it because the data is now becoming old as we speak. So you have the core idea, you have the most learning part being done on previous data, but then you introduce constant data flow of the same data, but you also allow your algorithm to change itself, to learn new things. Because, hey, here is an example. One of the things we found out that very much has to do with the patient length of stay prediction is actually the physician who is doing the procedure. And you can be like, hey, but it's kind of obvious. So, it's funny. We're seeing two physicians performing same procedure on somewhat similar people. If you clean out all the things that can intervene with the outcomes like age, gender, comorbidities, and everything else, you leave with a core procedure and a similar patient population, and you see that one after another, physician X patients stay longer than physician Y patients. So you don't really know why. Maybe you don't even care at this point why, but you know that length of stay of that particular physician is higher than the others. Now, this is just one data point among tens of dozens data points, but it's a very straightforward data point. Now, if you let me evolve that idea, now imagine yourself that physician Y has been working for this facility for, I don't know, last 10 years, and I trained my algorithm on that data. Now a year passes by, that physician leaves the organization and goes somewhere else, retires. It kind of scrambles my data, now there is a new physician introduced, and I'm kind of blind. If I don't introduce new data constantly, my algorithm will become older since the day it finished its learning. So this is about the algorithm and the technical part. Now, how this whole prediction thing is being used by the end users in the real unit. There are two scenarios. Imagine yourself a head nurse building a schedule. That's scenario number one. They look at our platform and they see that in the span of 2 weeks, 3 weeks, 7 days, depending on the facility's needs, they know how many people they need to put on any given shift into the future. For example, next Wednesday, I know, the platform know that you need 4 nurses. For example, doesn't really important how many in real life, but 4 nurses or whatever. And if you are being skeptical, you could be like, well, everybody kind of knows that, right? That's correct. But there is also some level of uncertainty always. You cannot predict 100% cases what it's going to look like into the future. Somebody's going to call in sick, somebody want to swap a shift, somebody I don't know what, but the most important thing, your census might go up and go down, or your patient's score, patient acuity score can change. For example, you know that those patients are supposed to be discharged, but hey, something happened and they are not, and suddenly you have higher census and suddenly you short a nurse. Or vice versa, you put 5 nurses, now day before comes and you see that you don't really need 5 nurses, right? So you're going to put 4 and now it's a big deal. Nobody wants to get rid of a shift, 16 hours or 8 hours before the shift starts. People just want to work. They are ready for working. Same goes for finding somebody for that shift. It's very difficult. Now, if you know in advance how many people you need, you have some leverage. You are getting rid of this thin layer of uncertainty, but this thin layer is also a very expensive layer, because if I want to be sure, and sometimes I want to put my 5th nurse instead of 4th nurse because I sense that something's going to change, I'm putting a 5th nurse and suddenly I don't have any availability within my working pool. So I need to go to marketplaces, I need to go to agencies, traveling nurses, and this is where you spend most of your dollars. So I know it's a small thin layer of uncertainty, but it's most expensive one. Now this is the first scenario. I'm predicting the future demand and supply. There is a second scenario where I just want to log into the platform probably on a daily basis and check the changes, because census changes, prediction census, we are getting medical data, we're getting clinical data. Patient might suddenly change their acuity score or anything like that, something we calculate internally. And then I realize that something has changed from the day before, because hospital, healthcare, patients, sickness is unpredictable. Well, it is predictable, but it's highly chaotic and highly volatile. So you just want to log in and see the changes on a daily basis. Those are two separate scenarios, one longer term, one shorter term, but they combine together, give you a great picture of what exactly you need on any given day.
Yeah. No, those are two great examples. I mean, I love the length of stay example you gave with the two physicians.
Yep.
And then I think managing uncertainty is key for these like healthcare facilities, right? Like the cost of that adds up. If you overstaff or understaff over time, that's adding cost to already thin margins. So it makes sense to have to manage, like your platform sounds like it helps them manage that uncertainty. And it begs the question though, like, where does the data come from, right? Because the
Yeah.
platform, like you said, always needs data. Let's talk about that a little bit, because from what I've heard, like learned, like you guys have recently integrated with like PCC, right? Which
Correct.
for the audience, that's PointClickCare.
Correct.
And they're one of the biggest, most dominant EHRs in this space, right?
Yep.
Along with Matrix. Why was that important to like get that integration in place, and how has that helped your guys' like broader strategy with training the algorithm and helping facilities with predicting demand and other analytics?
So EHR and HRIS systems, HRIS would be Human Resource Information System. They're extremely important to us. And this is like a high-level statement. They allow us to supplement the services, and they allow us to consolidate multiple tools in one platform. Like what we did with our design partners with Asuta, our local design partners, a network of 8 hospitals. We have integrated with their procedure scheduling system, and now they can see the procedure schedule in our platform. Now, when you have that, you can now add extra layers on top of just showing data. We show the schedule, we think which is useful by itself. You don't need to switch platforms, burn time on loggings and 2FAs and all that. And then our algorithms shows when the particular patient after a particular procedure will be admitted, which is a predictive part that comes in play, to the actual unit. This is very useful for the head nurses. They can plan their shifts, they can plan admissions, they can plan discharge, they can get better control over the shift. So I kind of separated it into 2 layers. One, it's very useful if I can consolidate all kind of data points in one platform, and which is easy to use, and you can log in and see different pieces of it instead of logging into I don't know how many. I think on average, regular head nurse probably has between 5 to 6 different platforms on everyday basis. Like there is scheduling, there is something about the scheduled procedures, there's the actual EHR, I don't know, Epic, Cerner, or whatever, and then there is something else, there is HRIS that manages clock in, clock out, punch in, punch out, something between 5 to 6 systems daily, and probably have more which are less commonly used. Now, if you just count that, how many times I need to log in, get a notification about F2A, fail the login, do it again, and then I probably burn like 1 hour just logging into the system daily, right? It's kind of crazy. So
I believe it.
So it is useful on its own without actually doing anything about it. Now, then there is a step beyond it. I now possess the data. I can do something about it. Like the example I gave, we integrated with a scheduling platform in Asuta, scheduling procedures platform, not the nursing scheduling platform. And now we can predict when any patient will come from the OR based on what we learned about the lengths of the procedures, at what time during the shift the patient will probably arrive from the OR. When you know that, it's kind of great. You can, even as a bedside nurse, I know I'm going to get 2 admissions, I don't know, between 2 p.m. and 3 p.m., whatever, like an example. I can do stuff around that slot, and I can kind of be prepared for those 2 admissions during the time. Because even in my case, neurosurgery is a lot of operations, right? Mostly about operations, neurosurgery, right? And constantly get calls from the OR. Okay, the patient is ready to come up. And you're kind of never ready for that. We're going to get 2, 3, 4 patients from the OR, but it's kind of gamble. Maybe beginning of the shift, maybe mid shift, maybe end of the shift. Now, knowing that simply allows me to plan my shift better. Now, same goes for the HRS systems. For example, let's show data in one place. If I can get hourly pay, skill level, people constantly swapping shift, introducing changes, which is a huge pain for the managers. Now, imagine a scenario where several people want to swap shifts. And I send my request into the system, as do others. Platform identifies the best and the most financially correct swap option. Or if the pay is similar, simply automates the whole process, does the action, and only notifies the manager. Hey, look, something happened. I need your approval, because human factor is super important. Everything, after all, has to be verified by the human being and the real person. So what you get is the best skill mix on the shift. Patient gets the care they need. The organization doesn't pay extra for that shift. It's a win-win. Of course, the decision takes into consideration the other parameters: overtime, last shift worked, shift management, and so on and so on. But on the way, it saves tons of money for the nursing manager. So this was like HRIS example, where to make those decisions, I need to know stuff about my staff. It's kind of funny. And if I know all the parameters of my workforce, I can automate all those processes, because if two people want, even more than two people want to swap shifts, that's a lot of headache for the manager. You need to make sure nobody's, like more expensive, quote, quote. They have the same skill mix. Is it even possible? Maybe some of them just worked night shift and they're, doing something which is not appropriate. I don't know. Like, if I control the data, I can automate all those processes.
Yeah. I mean, it really sounds like this personally impacted you when you were in the neurosurgery ICU, right? Like you gave that great analogy. Like we were never really ready for patients, but you guys are trying to address that.
That's true.
Like if you just take the long-term care example, like a nursing unit head, is able to prepare for admissions. Like, okay, I have these admissions coming. And then I love this example, like you said, also of a regular head nurse may have 5-6 different platforms to have to manage, like HRIS, like their EHR, EMR, scheduling procedures.
All
but
that.
You guys are taking a different swing at it. We could take this data to from these different sources together to be able to then give an informed picture to that nurse, so that their day is not spent oh shoot, we have 6 patients being added to our census, scramble mode, No, it's very compelling. Now, I know you mentioned this Asuta work you guys are doing. And you said it's with a group of Israeli hospitals that you're partnering with. How has this shaped your guys' product vision, and what has been different about expanding into the US?
So I think it's kind of similar, probably across all the first world countries. But I mean, we started with Asuta because they have this Rise Innovation division, which are very open, all kind of innovation. They kind of innovation hub. They kind of assesses all kind of innovative solutions, and then they run small pilots. And then if they see the outcomes are great or at least good, they kind of handle it over as a potential product to the higher levels of the hospital, and then you do a bigger pilot or whatever. So I want to focus on the actual concept of design partners. You need somebody for the data, and you need somebody for the input about your product. So they've been great partners. They were and are major user of our system. There are tons of feedback we received from them is priceless. We are working closely with nursing leadership on all the levels, from the head nurses to the CNO of the flagship hospital in Tel Aviv, and to the CNO of entire network. Like I mentioned, there are 8 hospitals in total. You see, if you want to build a product for the nurses, you need to talk to the nurses directly since day one. We've been talking to them before we had anything to show application-wise. We studied the flows of each unit and their bottlenecks, the local demands, the problems. And based on their feedback, we've adjusted the platform, introduced features, sometimes removed things that weren't useful or weren't that great. And their opinion actually shaped the way in-house products look today. Now, the US healthcare market is different. It's much bigger. It's more convoluted. It's just different, and yet it is healthcare after all. So you can see multiple similarities. Leaders of organizations struggle with similar problem, rising costs, retention issues, burnout, and so on. So I guess when you kind of pull in the cultural, the geographical, all those differentialities, you see the same problems, and we are offering a solution to some of those problems. So I don't really think that same conversation was different with what we had initially with Asuta, and any other US hospital would be like, hey, you guys struggling with costs. Hey guys, you're struggling with retention. Hey guys, you're struggling with ABC. Yes, ABC is probably similar across many, many healthcare organizations in the developed world.
Right, right. Yeah, it's almost like this, like staffing is nursing staffing and other healthcare professional staffing is a global crisis, you know? It's not just like something you guys have seen in Israel, like in the US as well. It has even larger magnitude, I would venture to say. And then what I think was amazing from you, what you just said is like you guys have been building the product alongside nurses since like day one. Like really addressing their problems, like that's what's gonna be able to move the needle forward. And what are you seeing locally? You know, like how does this impact your workflow day to day? I mean, just understanding the different platforms that these head of nurses have to touch is a huge, you know, step forward. So it's pretty amazing what you guys are doing. Now, what is like next for you guys as you grow, you know, because this long-term care piece of the healthcare industry is quite big in itself, like you said. Are, you know, skilled nursing facilities your guys' primary beachhead moving forward, or do you also see like senior living communities playing a bigger role over time?
I think those things are kind of interconnected. You know, they're also complementary to each other. If I'm going back to our first question or the second one, where long-term care versus short-term care, it's kind of all embedded in. I mean, in-house health offers a portfolio of products, and there are different solutions and different products for analytics, predictive analytics, scheduling, as is. You know, some systems still use pen and paper, some still use spreadsheet and Excels and all that. It's still out there. So I cannot come to you and offer a sophisticated analytics predictive piece, and you are showing me a piece of paper and a pen, and it's just not gonna work. So I need to give you a basic tool where you can manage your shifts, and then on top of it. So you get the idea. It's like I need a portfolio of products, right? We can sit on top of existing systems like UKG, which is a big player in the US, and we can just offer the predictive ability plugin, and we don't replace any of the existing enterprise solution, because replacing one software with another is always a big issue and a big problem. So I can just give you a plugin for the UKG and be like, hey, you can still use all that, but here is a predictive analytics plugin that will show you the supply and demand possibilities and the action items you probably want to take. Yeah, I mean, we also intend to integrate with more HRA systems and HR out there to expand product abilities. I mentioned it previously. And I guess about the question if senior living community is going to play a bigger role, I think the hospitals is the place eventually where such sophisticated tools can truly show its potential. Just think about all the pieces that are interconnected in a big, like really big hospital. There is inpatient, there is OR recovery, there is recovery units connected to OR is connected to inpatient, there is step down units, there is ICU, there is imaging, and there are cycles of rotation of patients between all those units. Now, if you can manage it in a single platform, that's just amazing. You know, then there is outpatient, there is auxiliary workforce, dietitian, secretaries, all that, and this is where platforms such as in-house can actually show their full potential. You know, eventually we want to help as much of nursing and clinical as possible. And bottom line, hospitals are the largest employers of nursing. That's it.
Right. Yeah. Well said. I mean, and what stood out to me from what you just said is like it's important to like layer onto their existing stack, right?
Yeah.
Like you don't want to rip and replace an existing enterprise solution that it's going to cause more headaches for the frontline staff.
Yeah.
This layers on to their existing stack. That's what's most like important in terms of adoption, right? That's fascinating. And you know, for nursing leaders, you know, operators that are out there that are curious to learn more and, you know, potentially partner with you guys in the US, like what's the best way to get in touch or see the platform in action?
Yeah, I mean, I'm always happy to connect with everybody who's interested in learning more, or just chat. Just you can always DM me on LinkedIn. I promise I gonna respond almost immediately. You can shoot me an email. Also, please visit our cool website at www.inhouse.health. Sometimes I travel to conferences in-house. Other people travel to conferences. We're kind of trying to cover as much ground as possible. The CEO, the salespeople, all that. Follow us on LinkedIn. Follow In-House Health, and you're going to see all the updates. And hey, I'm surely like everybody. I'm happy to speak to everybody who's coming my way. Everybody else is also.
Yeah, amazing. We'll make sure to link, your LinkedIn in the comments and as well as your website so that folks can poke around,
Thank you.
check that
Thank
out.
you.
And
Thank you. That's awesome.
I think, this is a piece of the industry that has shaken up a lot since COVID. And I think I see the opportunity for you guys in the work you're doing. And I'm excited to keep tabs on, your AI driven scheduling and management platform. And the sky's the limit. Nursing is going to continue to grow in their needs
Yep.
and
Yep.
what and the capabilities that, companies like yours offer to them. So,
That's true. That's true.
yeah, definitely. So yeah, it's been a pleasure speaking to you today, Sergey. And we'll be keeping tabs on your guys' journey. And thanks for making some time to hop on the podcast today. For making it a very informative discussion.
Sure, Bert. It's my pleasure. Thanks for being guest in your podcast. And yeah, we'll be in touch.
Absolutely. Thank you.
Bye bye. Have a good day.